Franco Cappuccio is Professor of Cardiovascular Medicine and Epidemiology at the University of Warwick in the UK. He is immediate past president of the British and Irish Hypertension Society and an expert consultant to the WHO. Today he will be discussing challenges and concerns for academics and the scientific press in providing trusted information on the importance of nutrition for cardiovascular health.
Thank you very much, Donald. I'm turning slightly the attention to from the very topical COVID-19 issue, which is global and is acute. It's an infectious disease, it's killing rapidly millions of people, and try to find a solution into what is less perceived to be of vital importance. That is the prevention of chronic disease, the conditions that kill millions of people around the world, but slowly and steadily. Now, this talk I put together representing the content of a paper we just published is below. I can circulate for those who are interested. It's called Dietary Sodium Controversy, Issues and Potential Solutions. And I want to very briefly address the content of this as just to open up a discussion, rather, I don't want to use the word debate, a discussion on trying to gain more input from all of you. Let me just click next. Let me just do, yeah. This is next. Okay. Well, this is our declaration of interest of the four authors. These are my colleague from Calgary in Australia, in Canada, and my two colleagues from Barts in London. Now, for those who are not familiar, I will set very briefly in a few slides the background, the health background of what I'm talking about, without going into great detail. First of all, high sodium intake, which is the substance contained in salt, is, by your surprise perhaps, the leading dietary risk for death globally. To high sodium intake is attributed more than 1.8 million deaths a year, and in excess of 45 million DALYs, which are adjusted life years lost globally, and this is an estimate of 2019. Why is that? Because high sodium intake chronically, day by day, increases your blood pressure. Now, high blood pressure over a certain point sometimes is referred to as hypertension in the clinical field, and by surprise to many, is the first cause of cardiovascular disease. Cardiovascular disease includes attacks, strokes, renal failure, heart failure, and other vascular conditions. Now, we've known for many, many years that if we reduce high blood pressure, we reduce the risk of death, of morbidity, and disability from cardiovascular disease. And that's why millions of people in the world take blood pressure tablets to lower their blood pressure so as to save them from premature heart disease and strokes. Now, it is of interest that because of the effect of sodium on blood pressure, a reduction in the amount of sodium we eat, at least in the range that we found in human beings, lower blood pressure has been shown, but also lower cardiovascular disease and reduces total mortality. And this has been known for about 40 years, and I'll show you very, very few data on that, so that global health organizations, including WHO, supports public health policy to reduce sodium consumption in populations to help prevent cardiovascular disease. And this is now one of the 7 targets for the Millennium Goals to reduce sodium consumption by 30% by 2025, aiming at finally a 2 grams of sodium per day or 5 grams of salt per day. So where is the evidence? So the consensus has been for 40 years coming from clinical trials of reducing sodium in relation to the effect on blood pressure levels. And this is a summary slide, including for each study here. These are meta-analyses, they're not individual studies. Each of these lines is a pooling project of several randomized trials reducing salt, looking at the effect on blood pressure. So as you can see, a variety of meta-analyses, including studies carried out in people with normal blood pressure, in people with high blood pressure, or in mixed groups. And each one collectively as a group reported a positive effect in reducing blood pressure by reducing sodium consumption. And for those who want to do a bit of statistics, the confidence intervals, the variability is inclusive in each one. So each of these estimates are compatible with each other statistically. In other words, they are allowing for the role of chance. So reducing sodium reduces blood pressure. Now, here, in fact, these are studies from observational epidemiology, taking long cohorts of people and following them up for a long time and seeing how much the sodium estimated at baseline in terms of consumption is associated with the long-term outcomes from both cardiovascular disease or total mortality. Sodium intake in this particular studies, these studies were measured by the gold standard measures of 24-hour urine collections, measuring the sodium you put out in the urine in 24 hours, which is a marker of how much you eat. As you can see here, there is a graded relationship here and here, both for cardiovascular disease and all-cause mortality. The higher your sodium intake, the greater is your risk of dying of cardiovascular disease, dying overall. Not being content, randomized clinical trials are the gold standard to prove causality of effect. And this is a slide recently summarized by the US National Academy of Sciences, of Medicine, Science, and Engineering, a very highly reputable organization that's looked at all the data which report the randomized trials of sodium reduction and the effect on cardiovascular outcomes. There are very few studies, very difficult to do, which confirm a 30% reduction in the risk of dying for a difference in sodium intake from 4,000 to 2,000 milligrams per day. So the lower, if you reduce sodium, you cause a reduction in cardiovascular mortality. So it seems everything is fine. The problem arises now, excuse me, that in the last about 10 years, a controversy has been put forward, challenging the dogma, as they say, that sodium is, low sodium is good for you. And this is based on one of these presentations here, these studies. I published in a highly reputable journal that reducing sodium intake will increase the risk of death, particularly in the range from 4 to 2, which one I've just showed you by randomized trials prove that reduces sodium, reduces blood pressure. So that they claim that the policy, the public policy should be halted, and there's been representation of WHO to stop policies globally. Now, why is that the case? Very, very briefly, there have been a number of perusal of the scientific evidence provided by these groups of dissenting scientists, as I call them, mainly based on a couple of big problems. The concerns about the advocacy against reducing dietary sodium is based fundamentally on inappropriate research methodology and unrigorous research, with the low quality of data using the wrong method of measuring sodium intake by just taking a spot of urine and just one drop of urine. That clearly shows in this graph is a bias estimate of intake. So at the low level, they overestimate, the low level, they underestimate the real intake of sodium. And when they plot it for mortality in those studies, is create a spurious association with a J-shaped curve, which is not present if you use 24-hour urine collections. And these formulas to estimate have been highly challenged and really dissected in details. And nevertheless, these studies continue being published and referred to. So despite the low quality, there are numerous and often high impact journals, mostly by a group of close scientists, which are recruiting other views and featuring editorials, which are often with undeclared conflict of interest, which perpetuate and reproduce and continue publishing these studies and other studies with the wrong methodology, which is extensively being criticized in science, in writing. So we, as a group of scientists concerned about this, have started trying to understand why, and we have taken several actions, which I'm going to summarize very briefly. And we've listed our concerns by groups. For instance, and these are based on our personal experience and what you can call some anecdotes in terms of evidence. For instance, we have taken action some time ago in contrasting the Journal of Academy of Clinical Nutrition in the States, who published a supplement on sodium with all articles perpetrating a criticism against reducing sodium, funded by industry, where participants were advisors and consultants for food industry, when no disclosures were provided. Some of us wrote extensively to the editors, and although the omissions or journal policies were identified and notified to editors, no corrective action by the journal or disclosure was taken until 2013. And these are the articles. And just mind you, this is still being quoted despite all these arguments. The other problem that we find is in studies of public policy of interest, usually and mostly funded by public bodies, the replication of data is paramount. Some databases for these studies, which claim adverse effects, are not publicly available, although they're mostly publicly funded. We are finding very difficult at the moment to obtain access independently to this data with refusal from the original authors, not trusting, of course, a verification of their analyses. In some cases in the past, things did happen, and by independent verification, the results were corrected. And in one instance, for instance, a standard formula here, which inflated the data, proved to be wrong once was tested. So there are examples where independent verification reinforces the credibility of the scientific community to the claims on the data. Well, we also refer to scientific and professional conduct. Obviously, we do believe and we trust responsible science, which relies in granting agencies, reviewing grant applications and providing money for studies, scientific and ethical review process, to peruse the appropriateness of the research methodology before granting money and allowing studies to progress. Furthermore, for those who are not familiar with that, anything you want to do on the study data should be declared upfront and not post hoc. And there is case, particularly in the scenario I'm referring to, of several post hoc secondary analyses, which were not originally planned or reviewed, which have raised the controversy. There is one instance, for instance, where journals have delayed investigating overt claims made by some of us of concerns about papers published. And the retraction was grossly delayed. And once occurred, as in this example, we found that some authors still quote that study as an evidence. And it only comes to my mind disastrous examples of Wakefield and MMR cases that most of you will know, and how much damage that's done it. So this falls under the same category. Finally, we have identified faults and concerns among journals, granting agencies, research and ethics committee, where very often the flawed evidence is used and reused and republished, creating an aura of controversy and encouraging polarizations, when in fact they're all based on methodology that have been proven scientifically, at least challenged in science, to be wrong. Finally, we got the health and scientific organizations. I mentioned the false sense of equipoise and the credibility. The more you give space and platforms to dissenting scientists basing on low quality research their claims, you create an aura of controversy, and you also provide a platform of credibility giving the impression of equal representations. And that's the point I was going to raise earlier on, that the problems among scientists, because the two sides are both on paper credible scientists. And it's very, very difficult to dissect out who's right, who's wrong. Governments, sometimes I won't have to say that, it's obvious they're complacent about threats to evidence-based public policy. There are vested interests, there are lobbying against policy implementations that might concern business and other political beliefs. So what is the action? I think we feel very strongly that we are at the turning point, at least in nutritional science, where there is long-standing lack of ethical guidance, and we refer to all stakeholders. I mentioned earlier on the media, but we start from the granting bodies, we start from scientists themselves, to the editors, to the publishers, and everyone. Now, why is that important? Well, this is, we need not to forget, many millions of lives at stake here for reducing sodium, which seems such a trivial thing. And the guidance and standards of acceptable and unacceptable conduct is therefore needed. Academic organizations, for instance, should strengthen guidelines. Funding bodies should seek more rigorous design and methods. And editors sometimes have been negligent in publishing quality research. So in conclusion, we discuss the experiences of observation that relate to undermining the evidence supporting a moderate reduction in dietary sodium as a public health policy. We report the concerns that plague science, in our view, even outside the health field. And I just want to refer to climate change, where there are very similar actions happening. And I want just to refer to what has happened in the similar matters in the past on tobacco smoking and health. We raise issues that are critical for society to address. And I said, if anything, to maintain public trust in science. We share with many scientists the desire to discover the true relationship between sodium intake and health outcomes, particularly given that millions of lives are at risk. But we all play a role in safeguarding science. So I think we need to collaborate, and we believe we need to include the ethics group to develop, implement, and enforce higher standards to safeguard public policy. Thank you.
Franco, thank you very much indeed for a very clear presentation, a very worrying presentation on a number of counts. It really calls into question the ethics of academic researchers, but also the journals themselves. I suppose two obvious initial questions while our audience may be coming in. What have you been able to do? You've tried to address it through correspondence in the journals. What have you been able to do outside, or what other steps do you think are practical to try to address this? Because clearly it's a very difficult, long-standing issue going on here.
Okay, I think on this we've been working in a large group, in part individual, in part collectively, for many, many years, as you probably know. And there have been some successes like retraction of papers. The problem is still unclear for most of us why some scientists take so much credibility on the basis of science, because it's very difficult to differentiate we stick to the criticism of science, and there is a risk among scientists to fall into the trap of personalizing the criticism. Because at the end of the day, there are always some leaders and some followers. So I would like to stay away from identifying any particular individual scientist, because over the last 20 years, 15 years of this descent, many have joined in and have come and gone, and the funding behind, the conflict of interest behind, they've moved and changed with the world. First was industry and personal conflict of interest and pay, basically. And then came organizations, the race for funding and for accumulation of larger bodies of funding collectively, because the larger studies is considered to be better. And the argument that we have raised and proven in written papers all over again, the larger doesn't mean better, because if you have an error in your method, a larger study will produce a larger error. And this is where we are sticking to criticizing, and I don't go into the details, the technical details of the criticism, but they're all highly published. The problem is the denial of the other side. If you read papers that portray that sodium reduction is bad, none of the evidence that we have reportedly there is quoted. So we see his responsibility in the journals, in the peer review process, is a failure in the editorials, in failure in the granting bodies. It's all over. And why is that? Don't ask me why. The why is very difficult. But definitely this is picked up as in the media as a great headline, say, low salt kills you. Don't do it. And that's where we come into the media and the need to sensation, readership, and searching for quality of evidence. How does a media or a journalist ascertains the level of credibility? I heard what Isabella said, but it's very difficult, or even Wilfred, for a lay person to read and find out. When we say, is a vaccine good or not, you read. How many of lay people have knowledge of how a vaccine works and how it develops and what the side effects are? We're asking lay people to have degrees and knowledge that sometimes amongst scientists,
the way you're at a different level here, you're talking about the professional journals. They should have a professional editorial team. They should have probity in the reviewers. So you'd have thought that would help. I mean, the other obvious point is it is disappointing.
They have policies. They have policies. They all breach their policies.
But it's disappointing that these papers get through what should be a robust review process. And if you see what happens in the media, if there's an incorrect article published, they may have a retraction, but usually it's buried in page 26. So even if you get a letter published, it's not always given the space it should be. An obvious comment and related question: if this sort of thing happens in the public, your washing machine fails or something happens, or the builder does something wrong, there is some ombudsman in the UK and similar in other countries to try to help you resolve this. Now, I'm not sure if our attendees are aware of this, but there is a committee called the Committee on Publication Ethics. And the whole point of this is to make sure that you don't get false authorship, you don't get issues with how articles are published, bias not being picked up or not being recognized. The challenge there is of course, this committee is made up of editors and publishers of one or two other individuals and organizations. But I'd have thought it's an obvious body at least to approach, and if they're unable to deal with it, then that itself raises the question about should there be some body independent of the journals, which can somehow be a right of address to make sure if this thing happens, you can't address in a normal way, you deal with that.
Yeah, I think that's correct. In part, it's correct. There are bodies, and I think each journal has got the ethical guidelines, and we have raised the issues of some of the big ones, and they go through a process, an internal process, and as you know, is an inquiry amongst yourselves. So you judge yourself. So you get no independence. And if you had any interest in publishing that in the first place, you're not going to have any interest in then retracting it later. The point you're saying is collaborating across the board with less vested experts. And I think we are moving towards the ethicists and people, expert in medical ethics, but not necessarily in salt reduction or cardiovascular or any other. And in the hope that could be more unbiased. And also we are engaging with lawyers, medical lawyers, academic lawyers, in cases where there could be a breach of things that be relevant. There have been cases where it's not our case for now, but because we don't want to polarize at the individual level, where organizations hosting particular scientists have been notified of potential concerns. Now, can you imagine nowadays, at least in Britain, but I think, I hope everywhere in the world, we cannot get money from the tobacco industry. Okay, so that's fine. I cannot get a grant for tobacco industry. If I do, I need to declare it. Probably my institution has a right to stop me from getting the money. That is a great success, but for nutrition, there isn't any of that. You can do a study saying that Coca-Cola is good for you and save your life and for kids, and there's nothing you can do. Now, for sodium, we're reaching the point of, for sugar, is the same. We're reaching the point that driving epidemics in the world, and still they're not considered at the same level. And you can even argue that it's not harmful.
As a final question, there's two elements. One is public uncertainty. The journalists pick up on this, and the journalists love to have conflict, and it gives them good headlines. But more fundamentally, the question is, are these publications having an adverse impact on what should be good public health strategy? And are bodies such as the WHO aware of the bias, or are they susceptible to the information coming out here?
Well, I can tell you that I'm happy about the WHO to continue their program. And there's also another big organization now funded by the Bill Gates and Melinda Foundation and Bloomberg. It's called Resolve to Save Lives. And they are fully committed to the prevention of cardiovascular disease through salt reduction and blood pressure control. And they are moving on irrespective of that. But this is what we call a spanner in the wheel continuously, because there have been continuous rumors to shake the certainty of those who operate in the field, which are not always very, very tight scientists as we are in this field, but they are the next level of public health. The policymakers are not always very technical, and they rely on people like us. And when they are challenged, they become shaky in their political decisions. They can be criticized by then the political side. And there's always a politics in there. Now, making a decision to reduce salt at the country level needs a very strong representation from science to persuade a usually reluctant political side to implement, as you know. It's been for tobacco, it's been for sugar, it's been for fat, trans fatty acids, it's been for sodium, and so forth. So when you shake the certainty on science, you shake the political determination to continue. So it is a problem.
Well, on that key point, Franco Capuccia, thank you very much indeed for raising these key issues. I'd like to close the session by thanking all our panelists today, to thank our attendees from around the world for taking part in this. And if I could just share my screen briefly, just to highlight what's coming up in these future sessions, do join us. We will send you an email so you can be kept up to date with what's coming up and who's speaking. I share my screen. Here we go. You can see that the next session is coming up at the end of August on AI, what it can do for us in the homes and hospitals. And the further sessions coming up in September on equity outcomes. What about international equity in terms of geopolitics and price of medicines? And lastly, in the month when we have the International Climate Change Forum in the UK, what about climate and health, and why should we be concerned? So on that note, thank you all very much.